So I am so pleased to announce and certainly to introduce Dr. Michelle Hermiston. She's the Dean of College of Health Sciences at VinUniversity in Hanoi, Vietnam, where she is building cutting edge programs to train the next generation of health leaders. Before that, she spent over 20 years at UCSF, pioneering advanced and pediatric oncology, immunotherapy, and global cancer care across Southeast Asia. She now advises international organizations on education and cancer research worldwide. Please join me in giving a warm welcome to Dr. Michelle Hermiston.
Thank you for the kind introduction and the opportunity to be here. This meeting has been fantastic and was definitely worth the long flight. I have not taken the typical academic route. I actually grew up in the Midwest. I'm first generation college grad, grew up on a farm in Iowa, spent 8 years in St. Louis, and then moved to there we go. San Francisco for my residency and pediatric hematology oncology fellowship, and then had the good fortune of being able to stay for almost a quarter of a century, which seems like a long time. And then about 11 months ago, moved to Vietnam to become the first vice dean of health research, and I became dean about a month ago. And when I was in Vietnam, I had the pleasure of meeting Nitesh. And in 20 minutes, I somehow ended up getting invited to give a keynote talk here. And I don't do AI. I appreciate the use of it. And in my current job, where I'm expected to accomplish a lot in a short amount of time, it's a very necessary tool, but I certainly am not an expert. But this is the slide that made him say, I need you to come give a keynote talk. And so I have had the privilege in my career of spending time being a bench based physician scientist, moving into clinical trials, ultimately getting to develop and lead our CAR T cell, which is cutting edge immunotherapy program at UCSF, and being involved at a national level in the children's oncology group and getting to design a lot of clinical trials. During all of that, I met a resident who asked, would I give a talk in Vietnam on HLH, which is a very rare disease, but much more prevalent in children of Southeast Asian descent. And I said, sure. I was also the fellowship director, and I was always looking for fellows. And so I was like, tell me about your project and what you're interested in. And he's like, I want to improve cancer outcomes in Vietnam. He had grown up in Vietnam. He had done a rotation when he was a medical student at Harvard and was very traumatized by what he saw there, overcrowded hospitals, a very stressed system. And it's like, sure. And so I went in 2015 and then did a big pivot in my career and became much more involved in global cancer. And I think as I was sitting and listening to the opening remarks for this meeting, I was like, wow, my upbringing as a Catholic kid actually, I think, influenced a lot of that in that passion for equity and justice. And I think, something I never really appreciated, I think, until that moment. I think I'm the only pediatric oncologist in the room. So I'm going to give you a crash course of why I think I have the coolest job in the world. Leukemia is the most common cancer of childhood, universally fatal if untreated. And to me, this is the poster child for why science matters. Due to clinical trials and intensive therapy, we've taken this, and we is 9 out of 10 children are actually on a national clinical trial in the United States, and that is what has pushed these survival curves up so quickly. But in the 1960s, almost uniformly fatal disease. And because of cooperative group trials ran at a national level, we've been able to push the survival curves up to around 90%, which is really fantastic. And I think it highlights the importance of team science. I think the thing that's frightening to me right now as an outsider looking at the US is that funding for this is going away. And we don't cure 100% of kids, so the job isn't done. I think even though we can cure most kids, when you're a doctor on the front line, I can't fix 90% of a kid or 10% of a kid. It's all or none for that child. And I really don't like going to funerals. And so, I was very interested in what do we know about how do we cure this group of kids at this level? And One of the answers to that was, I'm going to go back for a second. As you notice, these survival curves got closer and closer and closer together. And while we used to make lots of impact, we weren't making much change in our last several clinical trials. And I think that reflects the fact that at some point, more chemotherapy is just more chemotherapy and more toxicity, but it doesn't actually improve your cure rates, and you need something new and different. And the game changer was immunotherapy. And so CAR T cells take our normal healthy T cells out of the body. We engineer them in the laboratory to specifically recognize the leukemia cells. We expand them in the lab and we reinfuse them into the patient. And that has been a game changer in my field and for also adult patients who have lymphoid malignancies. This is Emily Whitehead. She was the first child to receive these about a decade ago. She had multiply relapsed leukemia. The outcomes for that population of kids was less than 10%, and she's a long-term survivor, has graduated from college. It's super cool. And this is the exciting part. So for the population that these cells were tested in and approved in the United States, we only cured about 10% of those children, mostly because we couldn't get them into remission because they were resistant to all of the chemotherapies we had. CAR T cells still don't cure 100% of these kids, but we get 80% of them into remission. Half of them are still, cancer free usually after a transplant, not without even, another transplant at 12 months. And so that's very exciting. But what I started to become bothered by is that I had the privilege of doing this really exciting, caring for these kids with really exciting therapy. We cure 90% of kids with nothing fancy, drugs that are on the World Health Organization essential medicine list. And it's not just because we know how to do this well in the United States. If you look at any cooperative group around the world and high income countries, so in US and Europe, DFIC is in Boston, MOSPOR is in Singapore, St. Jude's, we all do really well. And we do really well with drugs that should be available to any child anywhere they live. And so, what is the state of childhood cancer in low and middle income countries? We don't have perfect data. And so that makes it a little hard, but all of the modeling would suggest that about 80% of childhood cancer burden is in low and middle income countries. And you could say, name your favorite disease. 80% of the world lives in low and middle income countries that don't have the same access to healthcare that we do. We've been talking about all these great things we can do over the past several days, but I think thinking about how do we take this technology, how do we use AI and actually get it to patients that live in most of the world is an interesting and important question. And that's what I'm going to talk through how we've approached that in our project. And now with the advent of AI, how can we potentially accelerate that? There's an increased prevalence of childhood cancer in low and middle income countries because the age population is younger. And there's also an increased incidence. And this is because we've actually done a really good job globally at decreasing under five mortality in most places around the world. Kids are no longer dying of malnutrition or infection. And so that means they live long enough to get childhood cancer, which you would predict based on what we know. And so this is the modeling from Carlos Rodriguez Galindo, whereas in the red line, as under five mortality drops, cancer goes up significantly. And in Vietnam, where I've been working and spending time in the last 10 years thinking about how do we improve outcomes, under five mortality has plummeted, which is fantastic. But every year, the hospital gets more and more and more crowded. And so, how do we deal with that? And so, to me, this is what it is the driver for a lot of the work that I do. Zip code is the number one predictor of outcome in kids with cancer. And to me, that's a disparity that we need to think about how to address. So, even though the medications are theoretically available, the outcomes are somewhere between, depending on your zip code, 5 and about 60% globally. And so, how do we fix that? And can we use these new emerging technologies to do it faster and better around the world? So I give this talk often to pharmaceutical companies because I do clinical trials. I have a lot of colleagues in that space, and then they hear about what I do in Vietnam. and then they become interested, and then like, "Can you give a talk?" And it's been interesting because I've been doing this for about 10 years, the shift in people who are starting to become interested. I'm not sure that it's really for ethical or moral reasons, but even if it's for financial reasons, it's exciting that pharma is starting to become interested in partnering in these areas. So I argue cancer doesn't discriminate, can happen to anybody. And children, your bad habits or those things, environmental exposures play very low risk. It really does seem to be mostly bad luck for most kids. Kids don't choose their zip code to which they are born. And so then the question is, do we have an obligation to all children to improve therapy? And if we think we do, what would it take to make childhood cancers improve in these settings? Pharma has become interested because we've ran out of treatment naive patients in the United States, especially for like CAR T cells. And there's an appreciation that we need to have more genetic ancestry diversity in our studies. And so going to other places has suddenly become interesting. And one of the first things I did when I moved to Vietnam was to actually establish a clinical trial unit and to establish that infrastructure. So, how do we improve outcomes? And this is where I think it gets challenging when we think about using AI. Improving outcomes in cancer is complicated. It's not, there's multiple places where you need to think about diagnostics, treatment, do you have the space? Is it safe? How do we get people who are remote talking about rural medicine? I thought was so interesting because it's the same problems that we face. I think, both in California and Vietnam are long, skinny countries, fairly similar. And a lot of the logistic problems are identical in both places. Clinical investigation, training people, complex procedures, psychosocial support, NGOs, government policy, all of those things are important and have to be addressed. And so, how do we do that? The typical academic approach is, you work on your little part of the elephant, and it's very siloed, can lead to lots of papers, but doesn't necessarily produce solutions. And so, in our global cancer program at UCSF, we took very mindfully an intentional approach of multidisciplinary team science that was really focused on solving the problem. So, our team had physician, had nurses, had pharmacists, had some public health scientists and child life specialists, and really took a holistic approach at trying to address the problem of infrastructure. Oh, interesting. The approach that we use stems from our educational approach at UCSF in terms of putting the problem you are interested in the center of the puzzle and appreciating that to solve that problem, you need multiple scientific lenses. And I think one of the things we need to think about as we think about new technologies and AI and accelerated approaches is that you need to think about all these things. COVID is a nice example. No one of these areas of science actually cured a single person. You really need that collective, integrated approach to address these things. And so I found it satisfying last night when Dale and the Telestra group was talking about how do they approach this. And you really need a strategic plan. And that was how we started in Vietnam. And I think as we're thinking about how to address these very large, complex systems problems globally, a strategic co-design approach is really important. And so this was a team of people. This was back in 2016, and we did a needs assessment and we took a national approach. One of the problems if you only partner with one hospital is that you improve things there, but that can create inadvertent disparities because you're lifting things up there and not in other places. And so we partnered ultimately with all 14 hospitals that care for children with cancer and blood diseases in the entire country. And in that needs assessment, we saw a number of things. And I think as we think about these technologies and how to apply them in these settings, you have to actually go and see what the setting looks like. So, this is Children's Hospital number 2, which is the largest and busiest hospital in the country. They see about 10,000 kids a day on the ward. They had 183 inpatients that day. They only have 120 beds. And in the country of Vietnam, there are only 2 hospitals that have a one child per bed policy. Think about that. One child, I take, at UCSF, we have only single rooms and they're double HEPA filtered and they're huge and there's a bed for the parent. and in this setting, open windows, immunocompromised kids for the physicians, neutrophil count under 500. And the infrastructure is such that, the international standards for nursing ratio for PT-MONC is 4 to 1. Their nursing ratio during the day is about one nurse per about 15 to 20 kids. And at night, it's 1 to 40. So when we start thinking about how do we implement these things to make it safer, you have to think about the context that that is happening in. And that's healthcare systems in, much of the world is very different from what we are privileged to have. So in our assessment, what we saw was a large number of children with cancer, lots of opportunity for impact, an overwhelmed staff with limited infrastructure. They were highly motivated and dedicated physicians and nurses. And I think that's been the most amazing part of this entire project. There was no mechanism for training. So a peds heme onc to be able to write chemotherapy, they did an adult rotation, adults and got an adult a certificate. Adults get completely different cancers than kids. Their metabolism is different. So no pediatric specific training and also no mentorship. What I think we had as an opportunity was a very inclusive international network with proven models and expertise. There was no research being done, and the opportunity for developing a collaborative group within Vietnam and a cancer registry, and the idea that cancer is hopeless terminal illness. Awareness support from local community and government is a way to address that. And so, because we were actually multiple institutions, we developed our own group that we that has members from actually multiple continents at this point for Southeast Asia, pediatric hematology oncology. And our goal was really to improve cure and outcomes of children with cancer and blood diseases. And our mission was to develop a cutting edge, competent, compassionate workforce that would be retained because turnover was a huge issue, and to think across the spectrum of who does it take to actually cure these children, so that you can't focus on only one group, but you really need to take a holistic approach. And I think as you think about using AI to develop new approaches, you have to think about the whole spectrum of what it takes from a patient journey perspective. And then, because I'm a big believer in those survival curves and that research drives improvement and outcomes, engaging in collaborative research, continuous quality improvement, and advocacy were key things that we wanted to work with our partners in developing. We initially focused on three areas: training and curriculum building, national consortium and unified approach, and data QI and research. We came up with a very detailed plan. I won't go into the details. And I think importantly, we linked it to tracking the outcomes and having ways to measure were we successful. The one thing I will say a little bit about, because I think it gets to what I have taken away from this meeting as one of the core things that we need to think about collectively as a community in terms of how do we use new technologies to enhance and address these problems, and that's training and curriculum building. So, if you only remember one thing about this, partnership is key, and there should never be anything about me without me. And so, you have to have your partners at the table. And I've seen multiple times where people design these beautiful things that are completely irrelevant in the context of what they're working. And so, we've been very purposeful in having our partners there at every step of the way and building trust so that we can actually accomplish things together. And I think from a global health perspective, if you're successful, you're no longer needed. As kind of like losing your job in many contexts can be a good thing. We partnered with the University of Medicine and Pharmacy, and they gave us several constraints. They wanted us to develop an education program that was patterned after the American Board of Pediatrics and graduate medical education requirements globally. They wanted us to teach in English, which is good because I don't speak very good. I can order a beer, but that's about it in Vietnamese. But teaching in English because it was the language of international meetings and wanting to get their trainees on an international stage, and then fitting it to the constraints of the country. So in the US, training is 3 years. There, we had to do it fit to a 2-year feedback. Our one constraint was a succession plan to ensure stability and sustainability and to identify who would be taking over before we started. And so we designed this as a train the trainer. with a plan of when it would be self-sufficient and went to the Ministry of Health, which from a farm kid perspective, in Iowa, there was kind of a wild experience. It's like going to NIH study section, except you're in the room while they critique you. But they did ultimately approve the program, and we started in 2019, and then the pandemic happened. But we were able to go through that. One of the things that I think I'm most proud of from this project is that we really thought carefully about how to do this. And when you develop something new, you don't have to follow the rules. And so we really thought about how do you train the 21st century physician? And I think this has relevance as we think about how to use these tools that are emerging to better enhance education of our workforce. So, from the perspective of how do you train people to treat and address health problems that have not yet emerged? And how do we train physicians to use tools, technologies, and treatments we haven't even invented? And I think two relevant examples, COVID didn't exist, right? When I was a medical school student and, we have had to deal with that problem. I ran a CAR T cell program that didn't exist when I was a medical student either. And I think in the context of the current era, and this is the challenge, this was about a year after COVID, 982 results. If you searched PubMed, less than a year later, that had gone up to 165,000 references. And that's the challenge is there's so much data. How do we teach people to find what is relevant? And that's the beauty of, I think, of AI and many of these coming capacities of being able to use these tools to help us be better physicians and to learn and know more. The problem is the quality of the data and is it applicable? And I'll talk about that in a second. We also decided that we would take a paradigm shift in the way that education, I think, historically has been done for physicians, and certainly in Vietnam, is that you focus on understanding and memorizing. So I study, I learn all this stuff, I take the test, I pass it, I forget most of what I've learned, and a real focus on memorization and recall. An alternative approach is to think about the fact that almost everything I need to know as a physician is in the palm of my hand. And how do I teach people to access that information? And in particular, I think that's important if English is your second language. And so everything we did was really focused on applying, analyzing, evaluating, and creating data and information and new processes. We used something that I led the inquiry curriculum at UCSF, and we applied this approach as the central framework for our training program. Identify a good question, find the relevant literature, evaluate that data, synthesize and apply it to your patients, recognize gaps and design solutions, and then reiterate that process. And we had multiple components to the curriculum, the foundational knowledge, but importantly, also clinical skills, developing meaningful research skills, formal training and quality improvement, and a large portion on professional development and leadership. I think one thing that happens globally is when you train people, they immediately will be thrust into leadership positions because there's a vacuum in that space. And so preparing people for that. And then there's the consideration. How do you train people if there's nobody in the country that's actually been formally trained? And so our approach was to co-teach with international and local faculty, preset a goal of developing additional academically focused graduates that would then lead the program. And we had it all nicely planned out. It was dangerous to be a friend of mine because then you were going to be teaching, and everybody did this for free. Everything was donated pro bono. But we had started with 54 faculty on 4 continents and truly the content experts of various areas of peds hem onc globally. Plan was that they would teach in for 1 week in country in teams of 2 to 3. Did a virtual orient faculty development, and at UCSF, I never had that many people show up for an hour and a half on a Sunday night, but people were really excited about this. And we now we're up to, I think, 78 faculty with a long waiting list of people that want to be engaged in this. And so I think that's one of the really refreshing and exciting things is just that people want to give their time. And I also learned a lot about Zoom and ended up getting tasked with leading our virtual learning environment at UCSF because I had been doing it in this context. But this was our first class of cohort of graduates, and we're now in our 7th cohort, and this is going forward very nicely. And I think having a ripple effect because our trainees are now training graduates, are graduates and training the next generation of pediatric hematologists, oncologists, as well as treating provincial physicians. And we've also used this to develop infrastructure in the region. Transplant is an emerging modality there. And so we have a monthly virtual meeting for transplant at a national level, now has expanded to, I think, 9 countries in the region. And importantly, having people who actually know how to do this in a setting that's similar. So Dr. Julia Palma is a transplant expert from Chile, and she's been instrumental in helping build this infrastructure within Vietnam and the region. So that's sort of how we approach that. How are we thinking about it now? And I've tried to cultivate friends who have expertise in AI because I think that's one of the really interesting and exciting things about this is it allows us to accelerate generating equitable outcomes. And we've heard lots of different things at this meeting, so I wasn't going to go into those in great detail, but we really can think about how to integrate every part of the patient journey using these tools to enhance and potentially accelerate improving outcomes. So, from diagnosis, medical imaging, pathology, and risk stratification, all of those projects are ongoing actually at VinUniversity and several institutions in Vietnam. Thinking about treatment from surgical robotics, pharmacogenomics, precision medicine, drug repurposing, and drug discovery all can, I think, be accelerated using the algorithms that all the computer scientists are developing. In terms of operations, we heard earlier today about authorization, refills, appointments, remote monitoring. We're now doing a project where we're trying to use essentially avatars to help with patient navigation because that doesn't exist. And when you have a ratio of one nurse to 20 patients, there's no time to do that. And so, can we use virtual approaches to help assist with that? Proactive health management, I think, is one of the most interesting things from the perspective of AI and the information that is there in terms of being able to collect information from people, personalized medication reminders, and symptom tracking. And one of the things I learned from one of my mentors is you can't cure cancer if they don't take their chemotherapy. And so, something as simple as having a remote monitor in the cap of the to know did they take it off and sending a text. And you can do that in a resource limited setting. Everybody has a phone there. And so I think those are things that are exciting and helpful. And then I think the thing we don't I haven't heard much talk about at this meeting, but I think is really interesting and important is how these new technologies can also empower patients, sometimes in a good way, sometimes in ways that aren't as helpful. But it does allow for enhanced health literacy with interactive educational content, patient navigation via chatbot and avatars, and connection to peer support groups. I think the part that is hard, and I think it's one of the values that I have learned from being in country and on the ground, is you have to do that in a culturally competent way. And so I was super excited last night at the poster session. Angelica Garcia Martinez had this is doing this beautiful work at empowering caregivers through AI, a culturally tailored chatbot for nutrition support in pediatric cancer. To me, this is super cool because there's no time to do teaching in these settings. And so can we automate some of this? And how do you do it in a way that is culturally appropriate? So I practiced medicine in San Francisco for 25 years. About 40% of our patients are of Asian genetic ancestry, about 40% are Hispanic genetic ancestry. Food is central to both of those cultures in terms of how parents care for their kids and those things. How those 2 cultures approach it, completely different. And so coming up with ways that are culturally sensitive and can be adapted, I think is really important. And so this excited me because I think a lot of these technologies don't take into account necessarily the local context. I think when we think about AI in healthcare, there's also a lot of challenges and things we have to be wary of. First and foremost, and we've been hearing about this for the last 2.5 days, is the limit is data. What you put in is what you get out, and how we train these different algorithms really depends on the data that you put in. much of that data does not include people in resource varied settings. There's also the privacy concerns and the ethical issues that arise with the use of sensitive health data. We have lots of rules about that in the United States. Those rules don't exist in other places, but we still, I think, have a moral responsibility to protect people's identity and personal data. There's lack of regulatory frameworks that hamper widespread adoption, and the regulations are variable and have lots of complexity. The thing we thought would be easiest to do in Vietnam was just to set up a cancer registry. That has ended up being almost impossible because we were partnered with St. Jude. They have a beautiful platform for doing that. We were we got a grant in collaboration with them to implement that. And then they passed a law in both China and Vietnam that with all of the Facebook things that you can't put data into the cloud. It's really hard to do a registry without that, and so then the workaround was, let's get RedCap in all of the hospitals, that's free, and have this reprogram this to have it at a local level. So there are ways to work around these things, but the regulatory context can make things challenging and a lot of delays, and it's helpful to think about that up front. Integrating AI into clinical workflows. People have asked me, what is the uptake in Vietnam? It's so much faster there than here. I think partly because they don't have all the regulation, partly because they're so overwhelmed and overcrowded that anything that can make their job easier is something that people will grab onto very quickly. And so you hear a lot more in that context than you do in ours, which is interesting. And then I think at the end of the day is you have to ask, does it save or increase time spent on non-patient facing tasks? So I've lived through four different medical EMRs, electronic medical records, and I can tell you that documenting before we had any of those things was so much faster because I can talk really fast and I dictate well. And while I appreciate the electronic medical record and preserving data, I also know that, we make dot phrases and we paste forward and all of those things, and it takes a lot more time. And as the law is that the attending has to write the note. So all of those things while well-intentioned, can take more time. And in a setting where they're so busy, thinking about those things carefully is critical. I also think it's important to remember that one size does not fit all. And this was another poster I really enjoyed last night from Zio Tech. And she is looking at Swahili in these and how do you process that in into these different data sets and algorithms. And one of the challenges is that there's a gazillion different dialects of that. And so how do you code that and translate that into electronic information? And so I think thinking about those things, if we want to make our data more inclusive, is going to be important. I think the other challenge is garbage in, garbage out. So I led the inquiry curriculum at UCSF for 10 years before moving to Vietnam. And we showed this as the second slide on the first day of medical school. Half of what you learn in medical school will be shown to be dead wrong or out of date within 5 years of your graduation. The trouble is that nobody can tell you which half. So the most important thing is to learn. To learn is how to learn on your own. That statement should actually terrify all of you who are doing AI and data. We do this big data, we throw it into the system, and that's how we train, in this iterative process. But if half of that is wrong in 5 years and we're using data from the last 15 years in healthcare, that should make alarms for all of us. And so I think thinking about this iterative process and how quickly we have to update things and that it's a very dynamic situation in terms of when we think about healthcare is critical. I also think we have to think about internal validity. And what that is essentially what makes it true. Is the data good? When you run an algorithm, and if you do it I was writing a paper, I have expertise in a rare disease called histiocytosis. And there were several of us from around the world who were going to write a review on, kind of current statement. And so we asked AI to write it first for us. Actually did a really good job. But what was fascinating was that it did lots of quotes of several of us, and all of the references were completely wrong. And so if you run, if you I use ChatGPT all the time, but you're like if you run a question just to check it in an area of your content expertise, and then you look at the reference, it's usually a white paper or something that's been cited, a lot, not necessarily the good data. And the part that I think is missing in this context is we also need to teach the bots are is the data good? Is there internal validity? Is it scientifically solid? And so we teach this particularly in Vietnam, and we do a series of journal clubs to help them think about these things and to really learn this skill set. And it's so interesting. They're student led, faculty facilitated, and it's so interesting to watch them learn how to really critically analyze data. But one of my worries is that in this modern era where it's so easy to type in a question and get an answer back, losing that critical eye and skepticism around internal validity. Equally important, and this is the third slide that we show both our fellows in Vietnam and our medical students, is really thinking about external validity. Does it apply to the patient population or system in front of us? And, I haven't heard any comment on this the entire meeting, but it's actually really important. So, does the data come from people that look like the patient in front of you? And is there a way that we can actually teach these systems to test and look for external validity? This is an example of why this is important. So these are 2 different studies. This one was done in France, this one was done in the United States. It took kids that were treated in France on French protocols or in the US on US protocols at children's oncology group sites and looked at their outcomes based on genetic ancestry. And in 2 different continents, 2 different, therapeutic regimens, if you look at the kids who were Vietnamese, they did substantially worse than kids who were non-Vietnamese. We now have some hints as to why that is, but I think it raises important questions about biology, unique social determinants of health. We know that Vietnamese children have a much higher rate of a polymorphism, so a change in one of their genes that metabolizes one of the key drugs that we use. If you are homozygous for that mutation, that polymorphism, you need only 10% of that drug to get the same levels as somebody who lacks that mutation. And so these kids die of toxicity because they're profoundly neutropenic in the toxicity of the drugs. So those things are really important to think about in terms of how do we apply the answer from ChatGPT to the patient in front of me. Were patients that look like mine in there? And if you have it, if you ask in your questioning to whichever chatbot algorithm you like best, restrict to Vietnamese patients, you get nothing back, because that doesn't exist in the literature. And that holds for most children in low and middle income countries. And so thinking about how do we improve the data is important. And then I think the final thing that I'd like to comment on from the perspective of a pediatric oncologist is how do we retain the humanism in the era of AI? And there are some simple truths. Caring for children, this is a slide that we share when we are teaching communication skills, but I think it's important to think about from a humanism perspective. Caring for children with illness is hard. Despite our best science, we are not able to cure every child. And people often say, oh, it must be so hard to be a pediatric oncologist. I'm like, no, I mean, I cure most kids. That's great. And for the kids that we can't cure because my field is so evidence based, it's really because their disease is smarter than our science. And that makes it easy to pivot and to walk with a family, to maximize the time that they have with the child, and to do your best to make the memories that they have meaningful. Every child and family's journey is different, but I think, the important thing is that we can always care. And so how do we retain that in the art part of medicine in the era of AI? And I loved what you said about the human touch, because I think that's what it is. And that's what excites me about the era we are in is that I so hope that all of you computer engineers can enable us to have more time to actually be with our patients and do the fun part of being a doctor instead of the less fun. This is Chris Adrian is was actually the day he started fellowship. He was one of my PT Monk fellows at UCSF. He was also named one of the top 20 authors under the age of 40 by The New Yorker. And he wrote this very interesting article called The Question. It was an essay that was in the New England Journal of Medicine that comes from the cocktail party question. So people ask you at a party, what do you do? And you say, a lot of times I'll just say I'm a pediatrician. Sometimes I'll say I'm a pediatric oncologist. And people go, oh, that's so hard. That must be so sad. And then they always have to go to the bathroom and you end up standing there by yourself. You don't know how to talk to you. But I actually think I have a great job. But what Chris picked up from interviewing all of the faculty in our division was that multiple people told him talking is the most important procedure of our profession. And I would say that that holds for much of medicine. How we talk to people, our words can be medicine. And I don't think that the computer is ever going to be able to completely replace the touch and the words that we can use with people. My hope is that they'll give us more time to do that. So, in terms of thinking about all of these different things that AI can do, what I really hope is that we'll bring back time so that we can actually do the job that is the most fun part of our job. So, in terms of takeaways, I think we're at the tip of the iceberg. One of my faculty is like, oh, no, we need to do a big survey to think of where, to see where people think AI will take us in 5 years. I'm like, it's changing so fast. We don't have a crystal ball. But I think thinking about what we should worry about and how we can utilize this to be able to take better care of patients is important. The challenges are significant. I don't think they are insurmountable. I think we have to have a strategic plan with all stakeholders at the table, and that takes into account the local context. We need to support generation of reliable and unbiased data. And that's the part that I hear missing in this. We're taking all this data and we're putting it in, but the data we really need still has to be done in many ways the old fashioned way, so we understand these different contexts. I think a perfect example was a talk I heard from a colleague in India a couple of months ago, and they took Western protocols, applied them to kids in India, and saw huge toxicity rates because they have so much antimicrobial resistance in that context. They modified the protocols to their context. Their survival rates are better than ours. And so I think that there will come a point where we will see much more bidirectional flow of information. It's hard to de-escalate therapy in the United States from an ethical perspective. If I can cure 90% of kids, should we step back on therapy? It's hard to sell that. But I think we can learn a lot from resource varied settings where it's safer to do that. And we're going to find out we don't need to give as much toxicity and exposure to these nasty drugs as we are currently doing. And then I think we need to keep the ethical aspects at the front. And I think we have to be bold and, to think big, to be a catalyst, and to think really end to end in this process. I have had the privilege of working with an amazing number of people from literally all over the globe. And this is really a very collective effort that I've had the privilege to be involved with. I wanted to say one thing about why, because I've gotten this question a million times. Why did I move to Vietnam? I did have a really good gig at UCSF, but I'm really passionate about wanting to improve access and equity in healthcare. And in Vietnam, I think we have an opportunity to be a leader in the region and beyond, and to develop a roadmap for both education and healthcare for other emerging countries. And when you look at those survival curves, emerging countries, I don't feel should have to go through the 5 decades to get to 90% survival. Can they leapfrog this, and can we learn from that collectively at a global level? And then at the end of the day, it still comes down to the kids. This was a child who was on death's doorstep at the National Children's Hospital I have permission to use this picture, in Vietnam about 3 months ago, and that was him 2 weeks ago. And we were able to get him, compassionate use because of these pharma relationships to a drug, because he was blasting through all of the traditional chemotherapy, and makes a huge difference. And so I think having the opportunity to increase access to these things is really important. So I will stop there and say thank you. I am hiring, so anybody who wants a real adventure overseas, come talk to me. I'd be happy to answer any questions.
I have a question. So, thank you so much. So my question is, so you've mentioned a couple of times, needing to adapt to the context you're in, right? So I'm curious, how when you went to Vietnam, how you know, h- what approach you took to understanding the context you were in, given that it's probably very different from ours, that it is very different from ours, and there's probably a lot of nuances to understand. So, yeah, just curious what approach you took to help you.
We were lucky in that we had somebody who was an ethnographer on our team and took copious notes, and then we fed them in to deduce and decoded them. And then I often took students with me who would play that role of just collecting the observations. So that was part of it, just being observant and curious. I think the second part was meeting with the right people. So getting stakeholders around the table. I think the third is that you have to be really patient. Trust, Vietnam is a really interesting place, and the United States didn't necessarily do great things over there for a period of time. And so there's always that question of how you will be perceived. It is a people that live very much in the here and now, but trust takes time. And so showing up and coming back, following through those things, then you start to learn. We supported a national consortium based on the Children's Oncology Group, and I think the fact that we were very clear and transparent upfront that this is a bidirectional partnership, that we are here to support you, but being very clear about, they want to do research, they wanna be on an international stage, that's really important culturally for them. I don't need to be the last author or the first author. This should be about you and how can we work together to get your story out there. And so I think those are the things, but it's very iterative. You can't fly in once for 2 days and think you understand their context. And then I think the other thing that's really important is that when you're designing things, you need to have partners at the table. And so I think a lot of global health, there's this whole concept of colonialization and global health and people coming in, taking data, taking samples, taking it out versus coming in saying, wow, this is a really interesting problem. How can we work on this together? Why don't you guys see, we'll do this in parallel in our two settings and then we can troubleshoot and those kind of things. So it's mindfully wanting to build capacity. And then you partner with them to actually do the studies and collect the data so you can actually feed it into the system and that becomes part of your database and you can start to pick out, is it similar or different and why is that? And thinking about it from a molecular level all the way to a systems level. But
Thank you.
any other questions?
So thinking about AI, I know some of the solutions I've worked on in the oncology space has been more on diagnostics, imaging, so more of using the readily available data. Given that you've seen the full spectrum of a patient's journey from, the onset of symptoms through the end of care, what would you see as sort of your first step of an area that you would like to solve for?
Where would I like your help in solving for? And, I think that, so where are the pain points? Like what are the things so that's a really complex problem, and I think there are multiple things you can do, and they don't have to be done necessarily sequentially. So, when I partner with people or when I have students who wanna work on a project, I usually start with what are you interested in? Because 'Cause you're more likely to follow through if it's something you're passionate about. I think when I hear you say diagnostics, that's a huge issue in that context. Learning how to do that. The fact that you can now look at specimens together or code them and all of those things over Zoom and teach that way is a game changer. The system is very, very overwhelmed there. So if we can come up with, that's where I think we can make a really big difference right away is accurate diagnosis using AI assisted methodologies. Same thing true with, if you have, the Bach Mai Hospital is the largest public hospital there. They have 19,000 outpatient visits a day. I'm like, I can't imagine that. You get me? Like, that's a ton, even for Mayo. And so, if we can use AI assisted methods to do the first preview on all of the mammograms, that would be huge, and then you can, follow that up. So I think the diagnostic space is really important. I think the second place that to me feels like, we can make huge impact is the operational part. So at the National Children's Hospital, they usually have 200 or so chemotherapy visits a day. They don't know until families show up in the morning who's coming. I write my chemo like a week in advance, and if you forget, you're getting paged by the pharmacist at 10 o'clock at night in the US. And so coming up with systems that allow them to track patients, to accurately forecast how much drug do they need, and those things I think is a game changer, and it's not that hard to do. And then I think the third area is really around how do we use AI and these technologies to get time for people. If you are one nurse per 40 patients, like we wanted to implement, there's something called pediatric early warning system, PEWS, that's based on vital signs and those kinds of things. You have to have somebody actually do the vital signs to know that they're actually, and if you have 40 kids that you're responsible for, that's not going to happen. So we actually are, like educating parents on how to do that. But, can we automate some of these things to buy time for people so that they can give better care? So I think those are the low hanging places to really start. But there's a lot to do. But it's I think the thing that's also exciting in this setting is that you're starting at a much lower place or with a lot more complication, things that you have to fix. So you see progress really quickly, and it's super satisfying and fun. And I think, you know, people in these settings are doing, I don't think I have an easy job. They have a really hard job, and they do it because they're so dedicated to these patients and these families. And so they make things happen in ways that don't happen in the United States. That's really fun and satisfying. So yeah, if you have any ideas, I can find a place to test them and implement them and people to partner around that.
Thank you.
So, this is just so heartwarming. It's a wonderful talk for the end of the day. Um, I was just wondering, especially when I think of partnerships,
Mhm.
and you've outlined a lot of things where partnerships could be really, really helpful to you and what can be done and amazing opportunity there. Um, are there things that, frankly, we in the US should be learning from what you've been doing in Vietnam so that your partnerships not only are feeling good about what they're giving, but they actually can see it's going to help them scale something better in the US too?
Yeah, I think, yeah, you're bringing up exactly like the centerpiece of our global cancer program at UCSF is all around bi-directional partnerships. And that's why I have a waiting list of faculty, because I think what people realize is that you gain much more than you give in this context, and you learn a ton of what is helpful here. So I went there because I have expertise in this disease called HLH. When I started working with the doctors there, and I mentored somebody to do a research project, and you start to learn from that, you're like, "Oh my god, I am completely overtreating these kids. How you do it is so much better. Let's de-escalate care." And now that's kind of becoming how we do this in many places in the United States. And so I think that we learn both directions, and that's the value. And if 80% of the world's population with name your favorite disease are in those settings, there's a ton we can learn, I think, that will be applicable in our context. And so, at least for childhood cancer, we're seeing a lot of that. And I think there's an appreciation that if we cure 90% of children, we're overtreating a whole lot of kids. And can we learn in these contexts of other ways to do this, ways that are safer or better? And in resource varied settings where you have much higher rates of antimicrobial resistance, they have to modify the therapy in order to not have kids die of toxic deaths. And when you see that those modifications, which are usually less intensive, give you the same cure rate, that informs what we do here. And so I think that there's a lot of ways that this can go back and forth. Learning how to give good care and get good cure rates with, fewer personnel. There's a lesson to be learned there. So I mean, I think I'm always learning things there. It's really interesting. Any others? Great. Thank you for your attention.